You are very nice. You really are very nice. And a lot of my friends are here. Milo, Mary. Dr. House, can I say this? Dr. House comes to every single presentation I make. Applause for Dr. House. And many others, of course. Oh, good to see you here. So, as always, I am honored and humbled to be in your presence. And it's not just the people I know. It's not just the group of friends that we have. It is the common purpose that unites us here. And what I want to talk to you about today is something that I hope is going to be, and then you close the door, is going to be unifying theme for all of us. The theme is, how do we impact medicine? I think of this as both the care we provide and what we aspire to do. One way of looking at this is that we are changing the paradigm. We are looking at this in an entirely different way. And I learned how to live my own life from my patients. So I use this as a background, as a source, as a deep well of what I'd like to share with you. We are putting the patient at the center of everything. That's not where, when you are patients and your loved ones are patients, that's not where you are. Being in the center of everything means that we no longer ask, what is the best thing I as a physician can do for my patients? It's more, what do my patients tell me that they in fact want? This is widening the horizon, opening the aperture. It is shifting the paradigm of medicine. So for example, you have a patient. The patient goes into a hospital. It's not like one of these jokes, a horse goes into a bar. Different. It's for real. So that patient goes into a hospital. And what does she want? So the first thing, I think, is she wants to come back out of there. Remember, we all are anxious. We all lose control when we are sick or our loved ones are sick. And coming back to your life, my life, is the first thought. And ideally, healthier than before. So the patients ask us, keep me safe. Keep me safe. From the clinical side of things, that means no necessary infections that you can always get in the hospital and not at home. You have to go to the hospital to get certain infections. No lapses in treatment. No errors in medical or surgical judgment. And we are working every day on having the quality and the operations running as seamlessly as possible. But as we all know, there are many therapies that are not free of risk themselves. The therapy comes with a risk. And that's where you need what we do at this University of Minnesota. That's where you need academic medicine. That's different than many of our colleagues in other realms of medicine do. Because you need to have that research angle, that scientific mind, that training that gives you an opportunity to look at how do you make the treatment itself safer. As many of you know, I am a bone marrow transplant physician. And since about 50 years ago, we have been using bone marrow transplant as a life-saving measure for a multitude of disorders, many of them cancers of the blood like leukemia, but also for genetic disorders. And the challenge there is, since that seminal discovery of Dr. Robert Good and his team at this university 50 years ago, we know that it comes with a great risk. You have to first wipe out the immune system of the patient. That obviously comes with a price in being vulnerable to infections. In fact, many other injuries can happen. Some of them are that when they do engraft with the bone marrow from somebody else, a healthy individual, it attacks the graft, it attacks the cancer, but also can attack different parts of the body. And so that we, every year, every decade, since that discovery in the 1960s, we've been improving the way we administer and maintain the bone marrow transplant. We have looked at things how not to wipe out the whole immune system. We have looked at ways, medications typically, how to help the body regenerate from the injury that it has withstand during the part of the before transplant, radiation and chemotherapy. And very recently, it has become possible to avoid the bone marrow transplant altogether by engineering the genetic data of the cells so that they target the cancer itself. So here you see that it is a more effective therapy and safer at the same time. All right, so patient goes to the hospital or a clinic, and what else he wants? In my opinion, he wants to be as little impacted by that event as possible. To go back to the family, back to the friends, back to walks in the park, going to the opera, rock climbing, and not seeing 3 16-page bills after all of this, right? We are done, right? It's all simple, clear. Of course not. So the organization, the clinical system, has to come forward and come with a system that will bring a single number you call, and you don't wait on the call half an hour listening to Schubert, nothing against Schubert, before you get to somebody who doesn't know. Okay? You need adequate time with your provider so that you are not waiting for 2 hours and then you are late to pick up your kid from the daycare. And you need a single, clear bill at the end of all of this that will be obvious to everyone. Now, the operations are obviously important, but again, academic medicine adds to this dramatically. Academic medicine is the one that will make medicine and the treatments simpler. So it starts with, say, a Robakin wearable pacemaker. You don't have to be hooked to a machine that stands like a fridge in the corner. You actually walk around. Pretty cool. In 1950s at this University of Minnesota. You can look at this as a development for a child with heart condition that instead of having to be reoperated every 3 years as she grows up, she will have a graft, a vascular graft, that will grow with her. That's simpler, right? Simpler is better in this sense. You can look at technology that brings us telemedicine, that we can go to the rural Minnesota and provide similar care we do in the metro. You can look at the 3D printing of skin and organs that are much, much superior to anything artificial that we can use. And then, again, you can look at the cells for the first time in the history of medicine as living medications and deliver them as the little transistors that you have in your iPhones that will know where to go, what to do, and where to stop. And that's effective and simple. That's the beauty of this. So that same patient or a hypothetical patient goes to the hospital or clinic, and What I think they think is they don't want to be there at all. They want to be away from the complex and convoluted system that medical healthcare systems today are. They want to be rock climbing. They want to be somewhere else, even at work. And we put this in front of them. Now, the challenge there is that the way we look at the healthcare system today is not making it easy for us to focus on their health rather than on their sickness. Because the compensation system that we are all faced with is based on procedures. You go, get a surgery, go, get a scan, you see someone. We are paid at the time that we are treating the sickness rather than at the time that we are treating something that is not yet sickness, but maintaining, regenerating health as such. So the patients say, focus on my health. That is going to be difficult because you have to change the sick care system to the healthcare system. And you can do that. We actually have all the information to, not all the information, we never do, but most of the information to make that change. But it is upon us to lead that change. And it is upon us to also extend it to the whole patient. Because, as we all know, if that patient has no access to medications, if she cannot get on a transportation, if the housing is not safe, no matter what I do or my colleagues do in the clinic or operating room will not have the same benefits. And the academic medicine adds to it one new angle, which is the societal burden of disease is such that there is a subgroup of what I call disorders of despair. That is depression, some disability, addiction, maladaptation to adult life in a complex society. And what we have learned at this university, not me, my colleagues, is that the first 3 years of life, the first 1,000 days of life, are exactly the time when you need to intervene. They are exactly the time when you get the most benefit from being able to optimize how the brain is being built, and that has an impact in the health in the adult life. So, 3 things. They say, keep me safe, keep it simple, focus on my health. These are the marching orders from our patients. This will drive where we go with the clinical care, where the research goes, and this is why, and this is how we will impact medicine. Thank you, everyone.